Dear Pure Urology viewers, good evening one and all. I'm sorry that last two programs I was not available. My team has done. Today, actually, we are talking about the nerve sparing radical prostatectomy. As you all know, lot of research has happened on the robotic prostatectomy. In Western countries, it is almost 20 years now. There is nothing new, but people are doing a lot of research on how the nerves are distributed around the prostate. So many techniques have come to save the nerves, not only for the erectile dysfunction, but for continence and recovery of the patient in other terms. So to know this, in India, one of the surgeon who works with silently lot of numbers is Dr. Arvind Ganpule, sir. Everybody knows his simplicity. To be honest, he was the one in the initial phases of our career, inspired laparoscopic skills. When we were learning, he taught us how to do suturing. When we used to go to Nadiad, he was the mentor for all of us, how to hold the needle holder, what is azimuth angle. All this we have learnt in 2007 from sir. Over a period of time, Dr. Arvind Ganpule also has switched to the robotic technology as MPH has. Briefly to introduce about Dr. Arvind Ganpule, sir, I am sharing the screen. So this is the introduction. So thank you once again joining the Pure. The topic is nerve sparing radical prostatectomy tips and tricks by Dr. Arvind Ganpule, sir. Dr. Arvind Ganpule, sir, is Vice Chairman Urology, Chief Division of Laparoscopy and Robotic Surgery, Muljibai Patel Urology Hospital, Nadiad. Everybody knows MPUH is the one of the famous centers, so-called like Makkah of the urology in India. Maybe world across is one of the academic institutes best. He has 203 PubMed indexed publication to his credit in reputed peer-reviewed national and international journals, 23 book chapters, and edited 6 books. It's phenomenal. More than 200 is really phenomenal. He is a proctor for intuitive surgical inclusive and performed over 900 robotic surgeries. Not many know that. Independently on this platform, which include 43 robotic renal transplants also, recipients, I mean to say. He is founder council member of Robotic Urology Forum, RUF, and currently serves as treasurer of Robotic Urology Forum. He also has co-authored 3 important urology reference book chapters. What is Campbell Urology 12th edition? This is on chapter 95, lower ureter calculi. The second one is Hinman's Atlas of Urology 8th edition on percutaneous endopyloplasty. Smith textbook of endourology, which is again one very, very good book for endourology, in which he has written on PCN access under ultrasound. He has 2 patents granted by Indian Patent Office. One is patent number so-and-so with laparoscopic needle holder. I have this needle holder which tip is narrow so that you can hold the small needles in pyeloplasty. Patent number, another one is intrarenal pressure regulating system. In future, all these scopes will have pressure monitoring to know whether you are doing correct or not. He is currently the associate editor of the Indian Journal of Urology, that is our prestigious journal, and on the editorial board of World Journal of Urology. He is currently the council member of the Urology Society of India. With this, he is eminent faculty also, inspector and subject expert for the National Board of Examinations, New Delhi. So he has Best National Reviewer, Indian Journal of Urology 2012, Best Reviewer, Endourology Society 2013, 15, 16, Outstanding Alumnus Award 2015 in Kolhapur. So there is nothing better than this CV, but still is approachable, and we have to learn a lot of things. Let us focus today on nerve sparing radical prostatectomy. What is his perspective? It is very important topic in India because we are also detecting cases much early with PSA less than 10. So it has meaning. With this, we have chosen this subject. Thank you, sir, for patient listening, and over to you. Thank you once again for accepting the invitation.
Thank you very much, Dr. Chandramohan. It is indeed an honor to be part of this prestigious platform. I will just share my screen in a moment. I'm indeed indebted to Dr. Chandramohan, who has been an inspiration to one and all in the field of urology in India, as well as all of you will agree with me across the globe as well. Really, the work he has done through this platform is, I must say, it is worth mentioning, and it is an inspiration for all of us. So thank you very much, Dr. Chandramohan.
Thank you, sir.
Thank you. I would be very brief and to the point as far as this topic which is given to me, so that we can have some time for question and answers, which I know the format of this program, wherein a lot of Q&As are there, and actually an interactive program always makes things very attractive. So I divided the flow of my talk as follows: that initially for the first 30 minutes, I will talk about certain definitions, concepts, what does the literature say on nerve sparing. Then that is the soul of this talk, that is two technique based videos, and the videos are the best platform from where you can actually learn many things. And then I leave some time after 45 minutes for certain Q&A which comes from the floor as well as from the moderator. Just to introduce the talk, we all know that you all will agree with me that the incidence of prostate cancer is significantly going high, not only across the globe and in the West, but in India as well. And we are seeing that one testimony to it is that we are seeing more number of radical prostatectomies being performed in India with the onslaught of the robotic technology. But what is more important is that whenever a patient comes to you, one and all who are doing radical prostatectomies will agree with me that initially the patient is very much concerned as to what is the cancer control, what is the cancer cure. But at 3 months when he comes for the follow-up, he has got only two questions: sub urine leak ho raha hai, there is urinary leak, and secondly related to potency. And I feel that these two factors are intertwined with the technique of nerve sparing. So that makes this topic of nerve preservation very relevant. So it is not just for preservation of potency, but it is also for preservation of the continence. Both are very important. So what I'm going to do, that I'm going to talk on this topic. So these are 4 sentences which I'm going to elaborate one by one. So I don't have to tell this August audience what is the contribution of Patrick Walsh as far as nerve sparing goes. He was the person who actually described the exact anatomy of cavernous nerve and their role in ensuring good potency after radical prostatectomy. Point number two. It was Walsh who actually described that neurovascular bundles are not a mesh of vessels and nerves, but actually they are tubular structures which are along the posterior wall, posterior lateral aspect of the prostate. It is Walsh who had actually described it first. He also described that these nerve bundles are present most of the times posterior laterally, and they're symmetrical. The way they are positioned left side in the same patient, they will be positioned similarly on the opposite side. But an important point which come out in his papers, that he has mentioned that they are also present anterolaterally and sometimes even anteriorly. And that is the reason why there are so many techniques for describing nerve preservation, that these nerve bundles are not just posterolaterally, but they are placed anteriorly and anterolaterally as well. So a few fun facts. As you can see here, that Patrick Walsh, along with, you will always see these two names. One is Peter Donker and one is Herbert Leber and Eggleston. So, as I was saying, that these are fun facts. The fun fact is that Peter Donker was actually not a urologist. Peter Donker was his artist, and the nerve anatomy that Patrick Walsh used to see whenever he used to operate, those were depicted exactly in a proper way by Peter Donker. So that is the reason why you'll see in all these papers which published in 1990, 1983, 1982, the names of these two authors are always there. But it was this seminal paper in 1985 which actually gives the precise location of the the autonomic nerves, starting with the pelvic plexus and going up to the corpora cavernosa in a detailed anatomical study of these nerves. So that's what we are going to look into. So as far as the anatomy of neurovascular bundle goes, we have also already described it, but let me spell it out. The neurovascular bundle lies close to the tip of the seminal vesicle and travels towards the posterolateral base of the prostate as an inferior extension of the pelvic plexus. And this is what I was trying to show when I was trying to mention when I just spelled it out. That you can see over here. I'll just show it over here. You can see that the neurovascular bundles are present along the posterolateral base of the prostate. The posterolateral base of the prostate. They start from the pelvic plexus. They run towards the apex of the prostate till the membranous urethra. And what is more important, I have shown this box over here. That is what is mentioned in this point number 3, that there is a triangular space here. There is a triangular space. One margin of the space is the denonuclear fascia. One margin of the space is the prostatic fascia. And one margin of the space is the lateral pelvic fascia. and in between lies the pelvic plexus running into the neurovascular bundle. So it
Sir,
is
I
very
have a
important.
doubt here. Sorry
Yeah.
to interrupt.
Yes. Yes.
We concentrate so much on the posterolateral aspect when we are going to the prostate, but when we do in the beginning posterior aspect seminal vesicles, lot of people use cautery with scissors and dissect. People say there only we will lose some of the nerves. Ideal, if you wanted to do nerve sparing at the level of the seminal vesicle, which you have shown here, a thick bundle is going by the tip of the seminal vesicle. Usually one arteries may come, they bleed. There a lot of people will coagulate with left hand. What exactly we have to do at the seminal vesicle? Because this is the beginning of the operation. Can you tell in terms of surgery, sir, if you don't mind?
Yes, yes, yes. So actually, I was going to show it during the videos,
Surgery,
but here I will just elaborate because this is the right point, and that is the reason why I have shown these arrows over here.
yes, sir.
So now arrow number 1 here, you will see that in the video there are two videos. In video number 2, you will see that this arrow actually depicts the area in between. I don't know whether you're okay. This
I'm
one,
able
this
to see. I'm able to see the arrow
yeah. So
vertically down, blue arrow.
this arrow is in between the two vas deferens.
Yeah,
So whenever the first step in the prostatovesical junction is that you have to identify the two vas,
yes,
and then you have to go in between the vas. Now,
yes,
as a rule, you are allowed to use cautery over here for a very simple reason. You see that the yellow bands are not at all seen here.
not at all seen.
So there you are allowed to use cautery. But
Okay,
whenever you are going to come here at the tip of the seminal vesicle, you see exactly at the tip of the seminal vesicle, the neurovascular bundle is there, and it is emanating from the pelvic plexus over here. So as far as possible, don't go behind the bladder. Point number 1. Point number 2, you have to clip and be absolutely athermal at the tip of the seminal vesicle. You will always see the artery to the seminal vesicle there. Lift up the seminal vesicle. Don't go deep and apply any clip over there. So in that way, if you go deep, you are likely to cut the neurovascular bundle over here. So that is the reason why I showed you the arrow over here. This arrow is to show that here the cautery is allowed, here the cautery is not allowed. Here you have to apply it just above, just at the tip of the seminal vesicle. Don't go below it, otherwise you are going to clip the nerves over here.
correct.
Here why I have shown this arrow, because here comes the importance of one technique wherein they say something which is called as the high anterior release.
Yeah,
So what do we mean by high anterior release? If you see that if you go straight and just chop it off over here, you are going to transect the nerves like this.
yes,
So
sir.
that is the reason why you have to take down the prostatic fascia like this, like where the cursor is going. That is the high anterior release. And that is the same principle which Mani Menon has told, wherein he has described the wheel or the super wheel. Wheel means the curtain. What he's saying that you just bring down the curtain of the prostatic fascia from here. In that way, the whole mass en bloc will be preserved along with the neurovascular bundle with the fascia. So that is the next point.
But this should be done only completely intraprostatic tumor. Any nearer to the capsule, it is slightly risky, na, sir. A vague question I am
will
asking, but
it's not it should not be done whenever you means personally I would not do a nerve spare whenever it is an T3A tumor. I would
okay,
always do it in an T1, T2. That was the last moot point that I wanted to show. But when we are going to do, we will never do it whenever it is an extra capsular spread.
extra
And I
capsule.
believe that is also given in the European guidelines as well.
Yes, sir.
So on the profile also, if you see what we showed here is can be shown exactly in the profile over here as well. You can see the pelvic plexus. You can see the neurovascular bundles getting transformed into a bundle at the tip of the seminal vesicle. So you just imagine that you apply a clip over here, you are going to sacrifice a few nerves over here.
Yeah,
That's why just apply the clip. It should be a thermal here, a clip at the tip of the seminal vesicle. As you go along, when you reach the prostate, you will see that there is one more thing that you can see here. That is the anterolateral aspect, wherein you can see few more branches. That is the anterolateral part of the seminal of the neurovascular bundle, and the major chunk is posterolateral over here, which goes
okay,
into the corpora cavernous.
okay,
So in profile, it has become very clear. Starts from S2, S3, S4, forms the pelvic plexus, then transforms into a neurovascular bundle close to the tip, some part goes into over the anterolateral aspect of the prostate, majority on the posterolateral. This is the reason why you have to have an anterior release or the what I should say the super wheel or the wheel, and then finally into the corpora cavernous. Now, going ahead, this is what I described in the last this thing, that it was Tony Castello who actually described that actually the neurovascular bundle is not a single bundle. Actually, it is a single bundle with some amount of anterolateral aspect, wherein you will have a few more bundles there as well. So he has described it very nicely that the posterior nerves consist majority of the NVB descending distally and dorsolaterally to the seminal vesicle. Again, a very important landmark. And the anterior nerves run near the posterolateral border of the seminal vesicle. So yes, as Dr. Chandramohan just very rightly pointed out, that the tip of the seminal vesicle is the most important aspect where we are very likely to have a thermal injury if you don't do it thermal. And one more very important point, that the distance between the anterior and the posterior nerves is around 3 centimeters at the base, coming closer as you go near the mid prostatic level, and then they again diverge along the prostatic apex. Now again we are going into the bare basics. What are the types of what I must say nerve spare you want to do? So let's classify them in this way. Just for the sake of understanding, I have put in a box. Depending on the facial planes which are dissected, they can be classified as intrafacial, they can be classified as interfacial, or they can be classified as extrafacial. Depending on the direction used, they can be antegrade, they can be retrograde, or they can be combination of two. What do we mean by antegrade? Now, all of us attend all conferences. You will see that whatever we are seeing in conferences, all those are antegrade. But what you see, Dr. Vipul Patel he does it, it is retrograde. And whatever Patrick Walsh was doing, it is retrograde, because he used to disconnect the open surgery. He used to disconnect the urethra and then he used to bring it back. One more classification is based on the timing of the NVB release, whether it is before manipulation of the prostatic pedicles or if it is after the manipulation of the prostatic pedicles. Of course, this is very theoretical, the use of cautery, whether it is thermal or thermal. Of course, we are not going to apply any traction, but all said and done, whenever you are going to do surgery, it will be with traction. But as far as possible, try to be traction free, try to be not use any cautery. And finally, the last thing is whether you are going to do unilateral or bilateral. So here comes the very important and relevant part which Dr. Chandramohan had just mentioned. Whether you will do an nerve preservation when you are dealing with an extracapsular spread. Now, if there is a situation wherein we have got a young patient and there is an ECE suspected only on the left hand side, then definitely we are going to do on the right hand side. So based on that, we will classify it whether it's an unilateral or bilateral. But if suppose you have got an ideal patient, like say a 60 years old, he's having a low risk prostate cancer, he's having good potency, then the red box, this should be what we should aim at. It should be intrafacial, it should be antegrade. All neurovascular bundle release should be before the manipulation of the vascular pedicle. It should be athermal, traction free, and it should be bilateral. Now, actually, I always try to resemble this particular diagram with an onion. You imagine that what you are seeing here is an onion, okay? And this is the main core of the onion, and this is the shandy of the onion over here. That is the urethra. And you peel off the onion, and the outermost peel is the levator ani with the levator fascia. The middle one is the fascia over the levator. Then over here, the bluish one that you are seeing is the prostatic fascia, and this is the pseudocapsule of the prostate. I will make things very simple so that everybody understands. We just saw S1, S2, S3, pelvic plexus going into the corpora cavernosa over here. You just see that a few anterolateral nerves are going and traversing just over the pseudocapsule. However, majority of the nerves are between the levator fascia and in between the prostatic fascia. You can see it very clearly, and very few nerves are there on the levator fascia. So it is not rocket science to understand that if you are intrafacial, I can guarantee you that you are going to preserve majority of the nerves.
Sir,
and
one question here.
Yeah.
One question here. If you
Yes.
want to be intrafacial, right from the anterior surface, you can incise and develop a plane completely posteriorly, even though if it is small bleeders, like one layer directly from anterior part of, directly from anterior you incise and then keep on coming down. Can we do like that?
Okay, so I assume that you are saying that there is a situation wherein you have transected the prostatovesical junction, and after that you are talking, right?
No, sir. The surface of the anterior surface, whether you transect the urethra or not, you make a plane right in front, just below the bladder anteriorly. Develop a plane and then keep on taking the curve, peel off all the on the blue layer, so that all the fascia will fall away from the prostate. Can
That
we
can
do
be
like that?
that can be absolutely done, and that is actually one of the step of wheel or super wheel. Actually,
Okay.
it is a step of wheel which Manimenan has described. And the
Okay.
premise for describing this is that he was more concerned about these nerves which are
Okay.
going anterior. So he
Okay.
says that you go beneath the fascia and you will preserve those nerves as well. So that
Okay.
the enormous part of the onion you are taking out and rest peels you are keeping inside.
Okay. Okay. Okay.
So the same thing I
But
can
all is
describe it
done
like
with Caesar, sir. No hook, no cut, no Caesar.
it should be a combination of scissor and just pinpoint cautery.
Pinpoint
Scissor
cautery.
with
Okay.
just pinpoint cautery.
Because there will be bleeders, no, sir, if you go in that plane.
Yes, they will be bleeder if you is so they say that you buy nerves at the cost of bleeding.
At
You
the
can
cost of
buy
bleed.
you can buy neurovascular bundle at the cost of minimal bleeding. That is the thing that
Somebody,
was
I have shown
promised.
that somebody will be flushing with saline also to keep bleeders
Yes,
identified and touch it.
exactly.
Okay, sir. That is
So
also
so
like in a like in a penile surgery, what we do.
exactly.
Yes, sir. Okay,
So
sir.
here see posteriorly it's very important. Posteriorly you see that if you are seeing the means it's not just about the anterior layer. You can see what Dr. Chandramohan was saying was this prostatic fascia.
Yes,
If you
sir.
go in, whether you want to
Yeah.
go in between here or you want to go very close
Yeah.
to the capsule.
Yes,
Based
sir.
on that, you will decide whether you are going intrafacial or whether you are going extrafacial. So the box that you are seeing right now is the extrafacial one, wherein
Okay.
your dissection is on the endopelvic fascia, and here you are seeing the perirectal fat. So
Okay.
typically, this dissection will be when you are having a T3 disease. When you are
Okay.
having a T2 disease, you should not see the perirectal fat. You should be on the denonular fascia posterior. That is
Okay.
what you are going to see here. See, the arrow shows that your dissection is on the denonular fascia. Your
Yeah. Yeah.
dissection is on the denonular fascia. And you see here they have mentioned dissection on the endopelvic fascia. But when you go interfacial, your dissection is on the prostatic fascia. They have not mentioned prostatic capsule. It's on the prostatic fascia, interfacial. I can
Okay.
show you here. This is the plane, this plane.
Yes, sir. Yes,
Can
sir.
you see this is
Where
interfacial.
90% of the nerves will be saved.
Yes, this is interfacial and this is intrafacial.
Intrafacial.
Almost 95% of the nerves will be saved here if you go
Okay.
like this. So if
Yeah.
you see in between interfacial and intrafacial, the posterior dissection is same. But laterally in intrafacial, you will see the bare capsule. Laterally, you will see the bare capsule of the prostate. But interfacial, some amount of fascia will be seen on the prostate because you are
Yes.
not going very close to the capsule. But now it is like an tarazu, because on one hand you want oncological cure, there is a chance that you might have positive margin, and here you
Yes.
want to preserve the neurovascular bundle. That's what we will discuss later on.
Okay, sir. Okay.
So in profile, if you again go into the surgical anatomy, rather than going into all these things, you just concentrate on A, B, C1 and C2.
Okay.
A, B, C1 and C2. A, you see A is intrafacial. Intrafacial,
Yeah.
the prostatic capsule and the prostatic fascia. In between, if you are just peeling off everything, you are going to preserve all these things. You are going to preserve all
Sir,
these
one
things.
common doubt here, sir. Don't mind. As a beginner, I'm asking, if we go in that fascia,
Hmm.
where will the neurovascular bundle in terms of vessels? When will you deal the vessels if you go in that line?
So it will be based upon whether you are going to go retrograde or whether you are going to go antigrade. If you are going
Uh,
to go with the Vipul Patel's technique,
Yes, sir.
then in that thing you will identify the area of minimal vascularity near the apex. You will develop a plane at the apex. If this is the
Okay.
prostate, this is the
Yes.
urethra.
Yeah.
You will develop a plane over here. Here is
Okay.
the pedicle. Here is the pedicle.
Yes, sir. 1 minute, sir. I am not able to see your my arrow.
Okay, so
You move the arrow in the center, sir.
what I will just a minute. I will just try to
In
show
the
it over
in the
here.
video, it may come,
Okay,
but
in the video I'll show you.
okay, no
So
problem.
so just seeing the plane, A is
Yeah.
the intrafacial,
Okay.
B is the interfacial in between the
Interfacial.
prostatic fascia, and this is the levator fascia. Okay,
Yes.
C1 is actually you are not preserve. You are just doing a partial nerve preservation because these all these dots.
Yeah.
All these dots you are seeing is the neurovascular bundle. You are actually going through the neurovascular bundle. And whenever it is a T3, T4, you are going through C2.
Almost
just
abutting the levator muscle.
yes, whenever the levator muscle is bare, that means you are not preserved anything.
Removed everything.
You have removed everything. When you are going to see some fascia on the levator, that means it might be a partial nerve preservation.
Yes, sir. Okay.
Coming on this side, if you see the capsule, that means you have preserved very nicely everything.
Yeah.
So I was just talking about the fine balance in between potency, continence, and the positive margin. So these are the three papers which actually deal on that. So you see what Devin in 2019 he says that there are higher potency rate and shorter time to return to continence in intrafacial dissection. However, the positive surgical margin rates were higher in patients with PT3. So that is the reason on a personal note, I would never like to do an radical prostatectomy in an T3 disease. Sorry, a nerve preservation technique in an T3 disease. Because ultimately we don't want to have a positive margin at the cost of good potency. So there should be a fine balance in between two. There might be possibilities wherein you might have an unilateral nerve preservation, and on the opposite side, you can actually sacrifice it. So, Dr. Chandramohan, I would like to draw your attention to this paper wherein Curto found a positive surgical margin rate of up to 30.7%.
That is dangerous.
Associated with intrafacial dissection. But mind you here that half of his patients were actually T3 disease, and approximately T2 disease were half of his patients.
This is over enthusiastic approach, na sir?
Yes. So yes, 30.7% is too much. It should not be at the cost of potency. At the cost of positive surgical margins or poor oncological outcomes.
Yes, sir.
So this is the take home from intra versus interfacial, describing these 3 points. Although many studies report better outcomes following intrafacial technique, the question mark that should remain in the mind of the surgeon is that of oncological safety. That is something very important. Now we come to these 4 important workers who have done a lot of work as far as nerve sparing grading systems goes. One is Stolzenberg. What I would do that I would be more focused on this slide. You see that all these 4 workers, it may be Stolzenberg, Mondorsey, Ashutosh Tiwari or Shatloff. Shatloff is Vipul Patel's group. So Vipul Patel, Tiwari, Mondorsey and Stolzenberg. You see that they have used different types of classification grading. But what they have used is basically they have used the same thing, intrafacial, interfacial or extrafacial. These are the 3 things, and based on that, they are further classified into 4 types of nerve pair, 4A type of nerve pair. So that is something that one has to remember, that the gold standard is whether you have got intrafacial, interfacial or extrafacial. What the point I want to make out is the red box. What point I want to make out is the red box, that Stolzenberg has decided the facial pains depending on the periprostatic fascia. He decides whether you want to be on the levator fascia, whether you want to be on the prostatic fascia, or you want to see the prostatic capsule. What Mondorsey has done, that he actually goes posteriorly. He actually sees the bundle based on the venous structures which are available over there, posterolateral to the prostate. I'll show that in the video. While Ashutosh Tiwari sees for the veins. The veins are typically seen in one of the videos that I'm going to show. You'll be able to see the veins. I'll point it out that these are the veins that actually Ashutosh Tiwari sees, to grade them as grade 1, grade 2, grade 3 or grade 4. And then, of course, the landmark artery, he calls his LA. That is, he calls it the prostatic artery. And I was there with Dr. Vipul Patel around 12 years ago. Each and every case, he demonstrates that artery. So he demonstrates that artery and then comes to the pedicle. He demonstrates that artery and then comes to the pedicle. So his landmark is the landmark prostatic artery.
That artery will be close to the posterolateral surface of the prostate. He identified.
Yes. It will be close to the posterolateral surface of the prostate. If I can show you here. Yeah. So this is the artery that he sees. You can see it's a very distinct structure that is seen in all the patients. It is on the, this is the prostate, just for orientation of everybody. This is the prostate, this is the levator fascia. Here will be the urethra. And you can see this artery over here. And then he develops the plane near the apex. He calls it the avascular plane. And then he comes posterior. And that's why it's called as a retrograde approach. You see that the artery is seen very well. You can see he has gone intrafacial. You can see the pedicles are taken the last. You see the clip is applied last. I'll come to this a little bit later. We were discussing this thing that we were discussing this box, and this is the landmark artery which runs on the posterolateral aspect. But there is one more thing that we have to see is that what is the direction of the nerve spare? As in conventional open retropubic radical prostatectomy, as described by Walsh used to he had an retrograde approach for nerve spare. But we all laparoscopic and robotic surgeons, most of the times, will take the pedicle first and then go towards the urethra. So that in our terms, we call it as antegrade. So if I can show you here this cursor, retrograde is the way Walsh used to come from the apex to the base, but we go from the base to the apex, all laparoscopic or robotic surgeons. So this is the Vipul Patel's artery, which is called as the prostatic artery. And this is the landmark paper in which we have got Dr. Anand Krishnan Shivaraman in this paper as well. If you go into the annotations, the prostatic vasculature, he calls it as PV. In this case, it is the prostatic artery, which is seen very well here. It is large caliber tortuous artery, and the dissection plane is developed exactly where the thumb of the hand you can see. This thumb, this is the plane, this is the site wherein actually he develops the plane, and from there he works his way retrograde up towards the pedicle. So here you can see that bifurcation of the prostatic vasculature and the prostatic pedicle is identified over here. This is the prostatic pedicle. You can see the seminal vesicles over here. This is the prostatic pedicle, and this is the artery. And the C over here, he's trying to show that 2 to 3 millimeter of zone. This is this 2 to 3 millimeter of zone wherein each and every time he develops the plane and works his way retrograde. If I can show it in a more depictable way, in a schematic way, the neurovascular bundle S1, S2, S3 plexus goes posterolaterally. But remember, in our first 2-3 slides, a few of them went over the anterolateral aspect of the prostate. So what Vipul Patel has described, he has identified this artery. He says that you can always see this landmark artery over here, and just what I should say, cranial to this artery, you will see this avascular zone. There is where he uses his Maryland forceps and makes a plane over there and works his way up over here in this way. And then lastly, he takes the pedicle. And this is how he sees it. It develops the plane over here. This is the tortuous artery. This is the prostatic capsule. And then finally, he will be taking the prostatic pedicle. The video that you are going to see, both the videos, 2 videos I'm going to show. One is of the wheel and one video is of the way we do the nerve spare. You will see that we'll be always going antegrade. We never go retrograde. How about doing unilateral or bilateral? So obviously, if you do bilateral, the chance that the patient will be more potent at 1 year significantly goes out. It goes up exponentially. So if the oncology dictates, then it's always better to have a bilateral nerve spare versus a unilateral nerve spare. What about using energy? So again, Tom Hurling was the person who actually described the clipless, cautery-free approach for neurovascular bundle preservation. And what he used to do, that he used to identify the prostatic pedicle. He applies clip over the prostatic pedicle, and the results say that that helps us in improving the potency rate. And Dr. Inderbir Gill in his study also used the Doppler ultrasound, which was inserted transrectally. He used to identify the vasculature in the prostatic pedicle, clip the prostatic pedicle, and see where the neurovascular bundles are there. It's more of an theoretical importance, but these are the ways in which the functional impact can be improved. Coming to the famous Wheel of Aphrodite. The Wheel of Aphrodite, also called as the curtain of dissection, is a modified nerve preservation technique during which the prostatic fascia is detached of the prostate, and actually it remains as a supportive structure over the ipsilateral neurovascular bundle. And then actually the neurovascular bundle will be seen hanging along with the puboprostatic ligaments. So the puboprostatic ligaments and the bundles lying over there. I'll show it in the video. I think let's just jump towards the video. It will help you in understanding. For the sake of understanding what I've done, that I have made sure that the video lies over here. And then you can have the schematic diagram on this side so that we can understand what's going on. So let the video start, and I'll start from the beginning for the sake of understanding. The first step, obviously, in a radical prostatectomy is the dropping the bladder. And here, of course, this is not my video. Let me make an disclaimer over here. What the surgeon is doing here, that the surgeon is dissecting the lateral aspect of the prostate, and you can actually see the seminal vesicle on the right hand side, and you are seeing the seminal vesicle on the left hand side. And this is typically bladder neck preservation. You can see a long length of the bladder mucosa can be seen, and these patients typically have got very good continence. Now we come to the next step. Again, I will halt the video in between so that I can make my points. So we are going towards the right neurovascular bundle preservation. I'll just go back a bit.
This is the midline.
So this is the midline. This is the denonular fascia over here. If I can show you over here, the surgeon is in this plane.
Above that.
Yes, above that.
Above the black line.
Above the black line. Coming on the right side, now the surgeon is making his way along the neurovascular bundle, along the pedicle. So just for the sake of understanding, the levator fascia is over here, and this is the prostatic pedicle. He's applying clips on the prostatic pedicle. Now I'm going to hold the video again over here. In a moment, I'm going to hold the video.
Now he's going close to the.
Yes, now you see, this is the prostatic pedicle, the neurovascular bundle. You can see a thick neurovascular bundle and see that almost nothing is left on the prostate. So that's the reason why I've shown this arrow over here. Exactly, the surgeon is at this point. He is on the prostatic pseudocapsule. The prostatic fascia is actually lying on the neurovascular bundle. So this is typical of an intrafacial dissection. Again, you see, very minimal amount of tissue is left on the prostate. We'll see it again on the left hand side. So again, these are the prostatic pedicles. This is what Dr. Chandramohan was saying, that near the prostatic pedicles and at the tip of the seminal vesicle, you see that the surgeon is not using any cautery. Everything is clip and cut. And this is the horizon. This is the horizon. He's not going deep to it. If he goes deep to it, he's going to clip the neurovascular bundle.
That means he's as lateral as possible.
He's as lateral as possible. Correct. Now let me halt it over here. Now you see, Dr. Chandramohan, now
yes,
this is the prostatic fascia.
Yeah.
This is the prostatic fascia.
Little away.
This is the prostate. Yeah, this is he has not yet reached there, but this is the prostate. This is the neurovascular bundle.
Yeah.
And just see how he's going to work his way through. He's going very close to the prostate now. You see, you can see the pseudocapsule of the prostate. You can see the capsule of the prostate, and on the left hand side you can see the neurovascular. And I'm going to halt here again. This is the nerve which Ashutosh Tiwari would be seeing here. I'll just go a second behind. See, this is the vein. You remember that like Stolzenberg will use the prostatic fascia as a landmark. Vipul Patel, the artery. Tiwari will be using the vein. And this is the vein. Based on whether you are inside the vein, on the vein, he will decide whether you are intrafacial or you are interfacial. So you see, he is outside the vein. He is almost intrafacial here. And now here is the difference on how you are going to go this thing. Now DVC control is, sorry. Now I'll hold it over here. Okay. Now you see, this is the neurovascular bundle on the left hand side, neurovascular bundle on the right hand side, the prostate which is completely bare. We are almost on the pseudocapsule.
Yes.
So you imagine that if you go straight and cut the puboprostatic ligament, you remember that the nerves are going to go like this, very close, and then go on the membranous urethra. So if you are going to cut the puboprostatic ligament, a few of the anterior fibers you are going to cut.
Yes.
So that's the reason the DVC, they are going very close to the prostatic fascia and taking with the help of the energy source. Now you might argue the energy source might be a problematic thing. You can do a cold cut as well. So
that means they may not cut the ligaments also.
Yeah, you have to, if you are going to do a super wheel, super wheel, you can see that the puboprostatic ligaments will be intact over here.
So they will go right on the surface. Right on the surface at the apex, dealing with the dorsal vein complex.
Exactly.
Even
And
don't
this,
mind cutting with scissor.
no mind cutting with the scissor. You can just pinpoint, do an underrunning of the bleeding points if it doesn't stop. Here they
Okay.
have shown it using the energy source, and this should
Okay.
be the final picture always after neurovascular bundle preserve. You see that there is a thick bundle. The endopelvic fascia is not dissected; it is intact. The prostatic fascia is also over there, and this is the curtain that Mani Menon is always describing. It is a curtain that is the wheel of Aphrodite, which is the curtain is actually covering the wheel, leading to improved potency. This would be the final picture. What they are trying to show here is that this is the picture of neurovascular bundle. This is the prostatic fascia, and an additional there, because as you are describing, is it possible to go on the anterior surface and take the keep the prostatic fascia? Exactly the same thing they have done over here, and that is the reason that additional a few nerve fibers are also maintained, leading to an improved potency according to the literature. A few additional points which
Sir,
I
in that case, sorry to interrupt. In that case, you have to lift the prostatic fascia to go into the urethra properly. Otherwise, even in that bite also it can come.
yes, absolutely,
That means
absolutely.
the thin bite should be taken, only the spongosa and the mucosa, and not a deep bite. Otherwise, entire, even posterolateral, it can trap in the suture also.
What actually you are saying very nicely is that here you have preserved it so
So
nicely, and
nicely.
if you don't do it here, you are going to just
So
bunch up
all the
everything
efforts
and
will go waste.
will go waste at the apex.
Oh my
And that
God.
is one point wherein actually I feel that when I was a beginner, I
Yeah,
used to actually, I'm sure that I must have sacrificed a lot number of nerves there, because
yeah,
my concentration was exactly here, and you
yeah.
have to remember that how the neurovascular bundle goes. So you
In
should be
fact,
very
people use lot
careful.
of cautery here while cutting the peri tissue of the urethra. They cut only with scissor urethra. Rest of the tissue they use cautery monopolar and dissect. There also nerve can get damaged, I think.
Absolutely. So I think that is a bottleneck, and those are the pain
So
points
right
very
angle
much.
should be used. Right angle can be better instrument there.
Yes, in one way. Many a times what we do that we go because we don't practice super wheel or wheel. Somehow we have not been trained in that way, and I feel that although the literature says that there is a difference, we feel that our potency rates are also quite okay. So we don't practice super wheel. But what we
Okay.
do that we follow the same principle that uh, the workers of wheel have told. What Dr. Menon says that you go very close to the puboprostatic ligament. So we
Okay.
cut cold the puboprostatic ligament as well as the DVC, and then we underrun and pinpoint underrun the DVC. In
And
that
that
way,
closeness is towards the prostate. I mean to say
yes, in that
that
way we
that
do.
ligaments as well as the vein should be close to the prostate, not towards the
Yes,
pubic symphysis.
correct, correct. So in that way we are going to preserve the nerves.
Okay, sir. Right.
So these are a few ways in which they say that you will be able to preserve the nerves in a better way. If I may just summarize, I'm going to describe them in one slide each, but just if I want to summarize, hydrodissection doesn't have any meaning. Nerve spare and regius sparing, I don't think so. There is much different. Regius sparing is excellent if you want to do and if you want to have good continence. Continence is excellent in regius spare, but the literature says that the potency rates are same in regius space or versus conventional. I feel that NeuroSafe has got an application. I will describe what NeuroSafe is. ICG, which we use in partial ICG, they have used it. We have seen our friend Dr. Anup Kumar using the amniotic membrane. That is the bioengineered material. And of course, these are again of theoretical consideration, electronerve simulation, and so on and so forth. So Dr. Khurshid Guru was the person who actually described using the earth thermal NS technique using epinephrine. He used to inject epinephrine directly into the lateral pedicle with the help of an injection cannula. And he used to say that this hydrodissection actually helps in identifying the nerves and doing an avascular dissection in a better way. But he himself has said that there is no long-term potency outcomes. They are not different in either of the groups. Very candid opinion. As far as Redzius Spering goes, the first person who described Redzius Spering is Galfano and later on by Dr. Kumra. But you see that most of the reports say that the recovery rate of potency after this procedure, you read the last line, they are similar as in conventional nerve sparing RARP. So continence, definitely continence is better in Redzius Spering, but nerve sparing, the jury is open. What about NeuroSafe? So what is NeuroSafe? It is intra frozen section analysis of the posterolateral aspect of the prostate margin. in order to assess. Suppose let's take an example that you want to do an right-sided nerve spare, and you are not very sure whether there is an extracapsular extension on the right hand side. So what they say
Okay.
that you just take a frozen section from there, send the frozen section from the neurovascular bundle, see whether cancer is there, and then go intrafacial and preserve the nerves. That is basic principle of neuroscience. So you have to have a very robust pathology team so that they can do a very fast and very confident frozen section analysis to say whether you are having a positive margin over there. So Dinen was the person who actually is doing the largest multi-center single-blinded randomized controlled trial to assess whether neurosafe is very is useful or no. I feel that this technique has got an potential in understanding, and particularly in cases wherein young patients with bilateral extracapsular extension, we will be seeing many patients in our country. So
more scientific ना, more scientific लगता है.
it is more scientific neurosafe, correct. Then, of course, these are all theoretical. You identify the landmark artery and then inject indocyanine green and see exactly where the artery is, and then go very close to the prostate based on where the artery is. I feel it's very difficult to identify because the prostate is also very vascular structure. So because of the vascular of the prostate, I don't think so you'll be able to identify exactly where the artery and go into that plane. But yes, this is one of the way in which you can actually identify where the neurovascular bundle is. Then the methods of improving the nerve preservation are these dehydrated human amniotic chorionic membrane. This study has actually shown that there is an improvement in potency in that group in terms of SHIM score. This thing we have seen Dr. Anup Kumar using it as well as Dr. Vipul Patel using it. I think we have to wait for the data to become more robust before.
What exactly it is, sir? What exactly? I'm not understanding.
See, I will just tell you that this is an dehydrated human amniotic chorionic membrane, which is wrapped and placed around the neurovascular bundle on both the sides near the
After preserving, you will wrap with it.
Yes. So this chorionic membrane actually will help in regenerating the nerves.
Okay.
So long-term follow-up is awaited, but that is one way in which you can improve the potency.
Right.
Now we come to this video, which actually is our own video, which describes how we do nerve sparing. So as you saw in the initial video, I'll just halt it for a second. We are at that step wherein we have disconnected the bladder. You see that we have not incised the endopelvic fascia on either side.
Okay.
The anterior bladder neck is taken down, and now what we are lifting is the vas deferens. So on the left hand side, purposefully I have kept this schematic diagram so that you can understand what we are doing. Now we are going in between the two vas deferens. So you
no
see
neurovascular bundle there.
There is no neurovascular bundle there, and you will see, you just pointed out if I'm wrong, we have not used any cautery here. We are only using blunt dissection and we are using clips. Here cautery is allowed in between the vas deferens, but we are not using cautery here. There also, but the cautery is somehow allowed in between the vas deferens. As you go laterally, cautery is not allowed. So here this
is the area.
Exactly. Here you are going to clip everything. This is the prostatic pedicle over here, and this is the tip of the seminal vesicle. If you go very deep here and more laterally and deep, you are going to take down the neurovascular bundle. So that should be your horizon, and that should be
very close and horizontal.
Exactly. So you see that all clips are being applied till the tip of the seminal, and the extent of the dissection is that you have to catch hold of the vas, both the sides, lift up the vas, keep on lifting the vas till you see the tip of the seminal vesicle. That should be the extent of lifting up the vas. So you see here also you are seeing the seminal vesicle here. Here also medially you see you have started seeing the seminal vesicle here. Till you see the seminal vesicle, keep on lifting the vas. Keep on lifting the vas.
Don't cut it.
Don't cut it. Once you see the seminal vesicle, cut the vas. And that should from here onwards. And from here onwards, it should be clip and cut. Clip and cut. You see here also it is clip and cut. Again, the landmarks are very clear here. You can see the prostatic pedicle. You can see the tip of the seminal vesicle. You are following this horizon wherein you are not going very deep. You are not going deep to this clip. Again, clip is being used for applying the structures near the tip of the seminal vesicles. After this is done, you can imagine that both the seminal vesicles are taken care of. Again, some bleeding, but I'm not using any...
Wait, sir, wait. Now you have cut, go back, sir, a little. Now you have cut the posterior aspect, again clipping. don't you think the posterior part of the nerve plexus will come here after lifting the seminal vesicle?
Okay,
You have
a good
already
point.
divided the neurovascular bundle, but this step exactly where you are starting, you are again lifting some tissue and cutting with clip.
So just for the orientation, this is the denonular fascia.
Yes,
If I may
yes.
show you here, this is the denon. We are here on this here,
Okay,
and the
okay.
neurovascular bundle is going to be here.
Much
If I want to
lateral.
show you here, the neurovascular bundle is going to be here.
Much lateral.
Lateral, no clips. Lateral, no cautery.
Okay.
In the center, you have to go.
Okay, okay.
So now we go to the posterior. You remember those boxes, three boxes at
Yes, yes.
this time. Now you just recollect those boxes. This is the denomination. In fact, here we have gone wrong at one place. I'll show you where we have gone wrong. See, here you have started seeing the fat. You are seeing that yellowish fat over here.
That
So
should
let me
not be
stop
seen.
over here. Let me stop over here.
Yeah.
Now, when you are going to see the fat, this is the denonular fascia. This is the extrafacial plane. We have gone here.
Yes.
We have gone here. So now we need to course correct.
Okay.
So now you see how we have course corrected. Now again we have gone slow. We know that we have gone wrong. So we have gone a little bit towards the sky.
Closer to the
prostate, because again more intrafacial sort of plane. So here again some amount of fat is seen. Again we are not very sure. Again we are going slow. Still we are not seeing. So now the suction will come inside. See, the suction has come inside. A bit more traction. Go a bit more towards the sky. Now you see,
you
this
are
is the
getting
plane.
a loose
This is the
areolar
plane.
tissue.
This is the plane. So I'll stop again here. I'll stop here. Now you can see this is the denonvillars here.
Beautiful, beautiful.
This is the denonvillars, and this is the plane that we want. We don't want to go here. So again we proceed from here.
So now whatever the experiment you do in the midline, don't go laterally wrongly.
Yes. Laterally, still the neurovascular bundle is preserved. So this is what I'm trying to show here. That was the fat which I was going, and this particular thing should proceed till the retrourethral part. Let me halt here again. I'm halting here.
Do you think that the same principles will apply if you go first posterior approach? No problem. Because I do first posterior. No problem, na?
No problem. Remember that if you see fat, that means you are extra facial. You are below the denon's fascia.
That plane cannot be continued to preserve the neurovascular bundle.
Yes. If you want, if it's a T3 disease, you are fine. No problem. You have to take care of the rectum.
Right.
But if you nerve preservation, no. Now, just to come back to a nerve preservation part, you see that this is the neurovascular bundle.
Yes.
It's somewhere over here.
Yeah.
We are going posterior. The prostate is completely hanging above.
Yeah.
The prostate is completely hanging above. Now, this helps in two ways. If you go completely posteriorly, dissect and create a plane completely posteriorly, in robotic prostatectomy, you have got the fourth arm. Even the mantra robot that you are going to use, that will also have the fourth arm.
You lift.
So if the posterior dissection will actually help you in mobilizing the prostate in all the way around. So that is one advantage of dissecting posteriorly. One more advantage of going up to the urethra posteriorly is that whatever is remaining over here, you will be very close to the neurovascular bundle. So just go on, like this is the plane. Go on developing the plane here laterally. Go on developing laterally till you see the curvature of the prostate like so here. Whatever is going to remain here would be the neurovascular bundle. That's what we are going to see exactly in the next few minutes. See, this is the plane that he's creating. See, he's creating the plane. From the center, he's going laterally. From the center, he's going laterally. Again, here he's being very sparing with the cautery. Although you are allowed to use cautery here.
But here the bleeders will come, I suppose, a little bit.
Yes, that's why I use pinpoint cautery over here.
Sometimes annoying venous bleeders can make the vision little uncomfortable here if you do like this.
Absolutely. Now here I have done something which is 30 down. I'm sure that will be there in mantra as well.
Yeah,
you have turned the camera 30 down. So when you, 30 up, not down, 30 up. So now we are seeing from below up. So you see that the vision has also improved.
Yeah.
When it was 30 down, we were just seeing till this point. Now we are seeing till the retrourethral part. So this is an addition in the 4th generation intuitive robot wherein you can flip it very easily from 30 down to 30 up, 30 down to 30 up. So in that way, you will be able to go retrourethral and you will be able to see the urethra as well in a very nice way.
By chance, if the tumor is outside also, this amount of plane will not come also, I think.
It will not come because because whenever it is an extra prostatic extension, you also don't want to go very close to the rectum. Yeah, and you will be also a bit apprehensive in going very close to the rectum. Now you see that posteriorly the adenomyosis is completed. Still, this is some part which is still a part of the prostatic pedicle. Again, still now as we want to preserve the nerves, we are trying to do an cold cut. Till the point we start seeing the capsule. We want to see at one point wherein we see the curve. We have started seeing the prostatic capsule over here. Now, whatever is remaining here would be the nerve bundles lying over there. Now I know what your next question is going to come. You will see that at one point we'll be clipping it like here.
Yeah.
Now you see here that we are going to
This is
clip.
my
But
worry.
now I'll hold it here for a second.
Yeah.
Okay,
Yeah.
I
Yeah.
hold it for a second. Now the clip is applied over here. The prostate is like so.
Yeah.
Okay. This is the prostatic fascia somewhere. And the
Yeah.
neurovascular bundle are over here.
Okay. Okay.
They are
They
coming from
won't come
here.
so anterior. They won't come so
Yes.
anterior.
They won't come so anterior.
Okay. This is only area where I am confused.
So here on the floor, you will find the neurovascular bundle on the floor now.
Yeah.
Now you can
Okay.
still why we are applying, because it's on the floor, it's not over here, and you'll be started seeing the prostatic capsule over here, like so over here.
Got
Why
the
it is
point.
bleeding? Because some part of neurovascular bundle, the anterolateral aspect, we are not preserving in this thing. In super wheel, we'll be preserving even the anterolateral nerves. Here, some part of the nerves will be going.
So if you don't want that also, you have to cut and coagulate.
Yes.
If you want to preserve that small nerves also.
Yeah. So now you see how that fourth arm is helping you, and see the traction that is being given on
Yeah.
the denon-villus fascia. Still some amount of tissue is remaining and the capsule is not yet seen very nicely.
Caesar should be very good here.
Yeah, and you see that most of the time what the surgeon is trying to do, that he is trying to coagulate with the help of one tip of the Caesar. He's not using both the tips. He's using just one jaw of the Caesar, and then trying to coagulate. Again, see the fourth arm. The fourth arm is pulling the prostate on one side.
Yeah. It is holding on the top.
Yes, and then now you see this Abhishek, that is this water that they're putting on that thing.
Yeah.
So that helps in identifying. See this water. It will
Yes.
help you in
Yeah.
identifying exactly it is. So the assistant should be also in sync with you. Now you see the neurovascular bundle has started showing up over here. This is the capsule over here, and this whole thick bundle. This is the thick bundle that you are seeing down below the clips.
Yeah.
This is the bundle that you are seeing over here. It is getting released. The capsule is there. Now here, as against that, the video that we saw in the super wheel video, you see that we are going interfacial here. We are exactly, because some amount of fascia is remaining on the prostate. There, the prostate was bare. So this is a plane wherein I must say that we are over here in this plane, the arrow that I'm showing over here.
Yeah. Yeah. Yeah.
It
It
is
is
not
B.
very close to the
It's a B.
pseudocapsule.
It's a B plane.
Yes, it is the B plane. What you are exactly? It is
Not
the B
A
plane.
plane. Not A plane.
Exactly. See one more point, Dr. Chandramohan. See the fourth arm. The fourth arm is pulling the prostate on one side. We are doing the pinpoint coagulation. We are doing the left hand side. So the fourth arm is pulling on the right hand side.
Yes.
So now this is the anterior part of this thing. If you go here where my arrow is, if you go over here, you are going to transit some amount
All
of
the
the
anterior nerves will be transferred.
anterior nerve. So you see
Yeah.
that the incision is over here. The incision is over
You
here.
are rarely coming anteriorly at the along the curvature of the prostate.
Yes, and the vein that Ashutosh Tiwari was telling, this vein,
This way.
that vein. So that is actually part of the DVC. That is the vein that we are just keeping it with the neurovascular bundle. So
Fantastic.
at places we are interfacial, at places we are intrafacial. But the nerve preservation is very thick. You can see that this thick bundle is preserved over here, and the
Yeah.
capsule the surgeon is trying to show, the pseudo capsule is bare. That means if it is bare, that means the neurovascular bundle is preserved. So I think the point is made. We need not see the opposite side. The point is made over here, right?
Correct. 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 Correct.
So just before I conclude and I give the concluding thoughts, initially when Dr. Chandramohan, we were residents in 2005-7, we were told that there is something called as trifecta. But now what Dr. Vipul Patel says, that It is not trifecta, it should be pentafecta. So it should be perioperative complications, and the surgical margin status should also be included in the counseling with the patients. That is one point I wanted to make. What are the challenges in quantifying? The second challenge is that I feel that it is very difficult to predict the outcomes, because I feel that the outcomes depend on the patient comorbidities, the extent of nerve preservation, patient expectations, what was the frequency of intercourse before the RARP, and of course the surgeon's experience. Going a little bit further, I feel that you see that Vipul Patel, what he reports, what we Indians report, and what somebody in Korea reports, there is a vast difference in what they are reporting. So this discrepancy is because of the fact that we are not very sure what we mean by good potency. So that is something that I think we, as a group together, should actually investigate what should be the potency rates after RARP in Indians. That is something that is yet to be determined.
Yes, sir.
More point that I wanted to put forth, and I would like you to also give your opinion, that when we should do a nerve spare and when we should not, and how we should be counseling the patient. I would personally not be doing a nerve spare when I've got a suspicion of an T3A disease or a T3B disease. I would be always counseling the patient that there is a 50% chance that even though I try or attempt a nerve spare, that he will be impotent, which will require assistance while for gaining intercourse. It may be with either sildenafil or intrapenile injections. So I conclude my talk and thoughts by saying that nerve preservation during radical prostatectomy is key for functional outcome, not only for potency but also for gaining continence. And I feel that the best nerve preservation can be achieved with bilateral nerve spare to the maximum extent, using earth thermal techniques, avoiding traction, and having a thorough knowledge of utilization of the correct planes. So those were my thoughts. If there are any further questions, I would obviously be very happy to take them.
Sir, I have a very silly doubt maybe. Instead of having the clip, can we take a bite after dissecting and tie it? Because sometimes clip doesn't apply. A thick tissue you'll take and you'll press it. You'll go more posterior. 10 mm clip may go more posterior. Always I think that one 20 silk you take superficially, nicely you put it and then cut slowly and then separate and then go like that. Just doubt.
See, this is this only shows that you are doing a lot of radical prostatectomies laparoscopically, and of course with the mantra as well. This only this question that
yes,
the question that you have, the very fact that you have posed this question shows that you have got a lot of experience. This is the commonest problem of application of the clips.
Yes,
many times you get frustrated with the assistant that why is not applying it properly.
Because actually, space is not there. This is the only place where you don't apply the principle of dissecting the posterior space when applying clip. Even big persons on the tissue, luckily they get away, but unlucky then happens na. 5-10 clips they will waste.
I personally feel that if you are not able to apply a clip, it is the fault of the surgeon. It is not, as far as robotic surgery goes, it is not the fault of the assistant. It is the duty of the surgeon to give the assistant an adequate space to make sure that his clip applicator comes inside, number one. Number two, he has to always make sure that the pedicle is adequately dissected and he's able to see at least able to see the tip of his scissors. And then ask him to apply. And the third thing that the assistant can do is that if he is not able to apply the clip, don't try to engage the knob of the clip. Just go and hit it over there. If it doesn't hit, no problem. Just come out. The next time you go inside, you already created a space for that. You will be able to apply. Coming to your question, I feel that if in spite of all these precautions, you are not able to apply a clip, it would be a good idea that you cut it and then you underrun that thing, or only point coagulate your work. It might just mess up your field, but that is one of the way of doing it.
Sir, another question. This artery and vein, when you trace proximally, to what level they can be traced if you are really interested in microscopic anatomy? Ultimately, they are branches of the internal iliac artery anterior division. There is no doubt about it.
So I personally feel that the prostatic artery, from my personal experience, I have seen that Vipul Patel, each and every case, he will be able to see that artery. When I came, prostatic artery. But whenever I used to see here, I could never see it. So it all depends on.
I have not seen the way you are telling the diagram he has shown. I have not seen any of the surgeons showing the pulsating prostatic artery in the neurovascular bundle, I mean to say. They clip it, mass, cut it nicely. They will go posteriorly and say that I am on the capsule now.
So I think they have developed that eyesight, vision, and insight into it, and that's the reason why, as our experience will grow, probably we'll be able to see
What
all
is
these
your
things.
present choice? Do you directly go dropping the bladder in radical prostatectomy, or because laparoscopy, I go where we don't have problem. First, I go posteriorly a little bit, cut the vas and seminal vesicles. Then I will stop there. Then I will come anteriorly. I don't do anything about dorsal vein. Then I will go to the bladder neck, so that where irreversible open something happen, we will stop. Some part, then prostate will be moving here and there. This is non-nerve sparing. Then lateral pedal completely will clip it off. Then endopelvic fascia fully bared. Then last, when prostate is hanging, you can take nice bite so that you have leverage to this thing. After that, cut this thing. Then everything is under control. You proceed on that day in 2-3 hours, finishing laparoscopic radical prostatectomy. What is your current approach?
Okay, just to be very specific, as I'm trained at MQH, all surgeons who are trained at MQH, they will go anterior. We never go
Anterior.
posterior. We never
Okay.
go posterior. So it all depends on how you are trained up. Nothing against the posterior approach, because whenever I go for proctoring, in fact, the trainee surgeon will tell me that they will be more comfortable going posteriorly, because that's how they used to do laparoscopically.
Okay.
That is one point. But to answer your question, I will go posteriorly at times whenever I have got doubt regarding the operability. Like, for example, the patient on PSMA PET has got no distant metastasis, but
Yeah,
the MRI is
that is
showing,
totally.
but the MRI is showing and possibility of invasion into the prostatic fascia, the rectal fat, but not into the rectal wall. So we have given degarelix, whatever, and we are going ahead. So if I have got some questions regarding the operability, I'll go first posteriorly before disconnecting the bladder neck. That is the only time where I'll go posterior.
Sir, after cutting the dorsal vein, some people are cutting now blowly dorsal vein, whether it is nerve sparing or non-nerve sparing. They hold with left hand bipolar, continuously budge and make it black. Don't you think the postal, as the nerves come more distally, they will come slightly lateral and anterior? Such amount of buzz, even if you show nicely pedicle, such amount of buzz after cutting, won't lateral spread damage the nerves?
Completely agree with you. The
Or
point is
while
that
bleeding only take the bites. While severe bleeding only take the
I
bites.
completely agree with you. The dorsal vein can be taken cold. There is no problem with it. Even though if you don't add that air seal device, still you can cut it. There will be no problem. If there are any
Yeah.
pinpoint bleeders, you can just buzz them. But
Okay.
no need to do an bipolar. Just completely dissect it in that way, because we do it in the same way. Whenever you do it in that way, you will get a good length of the urethra as well as you will preserve the nerves very well.
Yeah.
So I completely agree with you that buzzing is not allowed. You can cold cut it, and pinpoint coagulation can be done, and then very meticulously underrun the dorsal vein
In fact,
complex.
one artery pulsating will be there. If you coagulate, rest of the things will be controlled.
Exactly.
Unnecessarily, vein need not, complete cutting of the vein is better than complete buzzing of the entire tissue.
Exactly. Whenever that pulsating artery will always be there, just pinpoint coagulate it, and never half cut a vein. Completely cut it, the bleeding will stop.
Yes. So this is the one thing. If you imagine, for example, completely detected PSA based and intra prostatic in the central part, can we do totally close intrafacial, complete, just above the peripheral zone? I mean, just capsular, complete, no cutting. Imagine, it's a well-known concept. For my level, I am asking that below the suspensory ligament, below the dorsal vein, laterally all capsule release, and posteriorly all capsule release, go on to the urethra and take it out.
So I think that's what Mani Menon has described, the precision.
This is called hood technique, so-called hood.
Hood technique, and later on Mani Menon has also gone a little bit further and described it as a precision prostatectomy. Precision prostatectomy, but I personally have got no experience on that, and it's coming from the big guns, so we need to just wait to see what the results are.
So there is a huge risk of recurrence if you do wrong thing here.
Theoretically speaking, yes. Theoretically speaking, yes.
And the last question, when you are doing nerve sparing radical prostatectomy, if you are hurriedly doing within 12 days of prostate biopsy, you see so much amount of tissue which is hard, like sometimes very hard. The good Caesar only can cut it. That time you think that you are cutting wherever you are getting the plane. You are not really dissect slowly. Sometimes we pull the prostate retrograde and then keep on cutting. Such
Personally,
cases, nerve sparing in early where tissue is there, fibrotic tissue, or post prostatectomy nerve sparing. This is the last question. I mean, I don't have experience. My experience
no,
anyway, it is laparoscopy. I don't have much experience.
I would first of all means as an institutional protocol, we'll wait for 3 weeks after biopsy.
So
I
better
know
to
that,
wait 3 weeks.
yeah, I know that people will differ on this, but we will wait for 3 weeks.
Okay.
The second thing is that MC tumor biology and cancer biology is the king. If suppose MP-MRI is showing, and MP-MRI also, I will not do it within 3 weeks of biopsy. The patient will come, biopsy comes, PET CT, I diagnose it, stage him, and then just before the prostatectomy, I'll do an MP-MRI.
But
Because
MPMRI is before biopsy, na, sir, nowadays? I mean, sorry.
many a times what happens that the patient comes with a biopsy,
Okay,
and the
right.
patient
For
comes with
your
a PET
center, it
CT.
is like that. For
And
us,
then
we
the
are detecting,
third or fourth day, the patient comes here and then say
okay.
ki saab kab karna hai. Then we say that we'll wait for the 3 weeks and don't do the MP-MRI right now,
Yeah, yeah.
because the MP-MRI will show a wrong some hematoma batayenge
Wrong
ki there is some
signals.
problem.
Okay.
So if MP-MRI is showing that there is no extracapsular extension, there is nothing, then you will find planes there if you wait for 3 weeks.
Yeah,
There
yeah.
is no question about it.
Correct. Okay, sir. I was just thinking, a simple prostatectomy when you do, there is a lot of tissue between the when we are taking the bites with mucosa. That is the peripheral zone, na, sir.
Yes.
After that peripheral zone, you are doing
Capsule.
this nerve sparing.
Yes.
Inside
Then
the
comes the
peripheral zone is the
pseudocapsule.
enucleation.
Correct.
Outside the peripheral zone is the pure intrafacial prostatectomy.
Yes. Now the screen share has gone, but if you go inside the capsule, from there the plane of the enucleation will start.
So some people
So,
are doing transvesically also this type of radical prostatectomy. Some people going to the directly peripheral zone, remove at the peripheral zone all around and pull it out, and then suture between the urethra and the bladder.
I know, but means
It's
I
to,
know I know they are doing it. But see, you run the risk of enucleating the prostate, particularly if you don't find the Denon-Wheeler plane properly.
yeah,
You
yeah,
remember
that's not
rectum,
correct.
Denon-Wheeler, you run the risk of going into the peripheral zone if you
Yeah,
don't
yeah.
have an eye on that shiny layer of the Denon-Wheelers.
Yes, yes. You have shown that nicely. One layer is seen, then you go anterior, then 30-degree anterior, then you have gone close, close, close. That is possible really for a benign, relatively benign intraprostatic tumor.
Even T1 disease, maybe
That's
TU,
too
that's,
close shaving of the prostate. And you continued back on the lateral surface.
yes,
And you continued almost, then you went outside the extrafacial, then you continued. So
yes.
partly in the posterior aspect, you shown intrafacial.
Okay, okay. No problem. No. Okay, okay. All the best. All the best.